So just a little bit of history. Every time we think that we've done something great, we need to go back and look to see, what happened before us. And I think it would come as a bit of a surprise to most of us that in 1896, there was somebody who was doing tendon transfers for radial nerve palsy and a tenodesis by shortening the ECRL. And it just goes to show that even at that time, with rudimentary anesthesia, perhaps use of tourniquet or not, sutures and so on and so forth, not a clear understanding of anatomy and biomechanics, there was somebody who thought about this a long time ago. We're not going to spend time talking about the principles because I'm sure that you've had this done before. But the only thing that I will point out to you is that one of the important things is we don't use one tendon for multiple functions usually, because you'll end up in trouble when that happens. There are some exceptions. I will talk about that during this talk, but that's the one thing that I would stress to you, that try as far as possible to use one tendon for one function. Now, this is something that I think we would probably want to spend a couple of minutes on, because this is crucial to our decision making. You need to assess the situation to decide, when somebody has a radial nerve palsy, whether you're going to approach the nerve, or whether you're going to simply do a tendon transfer straight away, or whether there is a case to be made for doing both things, and how to time them. So the first and most important thing for us to look at is we need to analyze the problem to see what's actually happened in the past. And in real terms, the single most important thing from our point of view is to know what happened to the patient at the time of the injury, who treated them, and what is the nature of the treatment that we received. And the other thing that we will discuss briefly is the role of early tendon transfers as internal splints. So if you have a radial nerve that's been injured, for example, if it's an open injury and somebody's been in there to look at the nerve at the time of the injury, what you want to think about is what was the quality of the primary repair? Because if it is a clean cut injury, if it's been done by a competent microsurgeon in a hand surgery center with a microscope, then the question that you have to ask yourself is, would you improve on that primary repair when there wasn't a loss of substance of nerve by going back in and grafting the nerve? Or is it that if somebody's done a good repair, it's unlikely that you're going to improve that and you need to think about something different? The other thing that matters is the level of the injury, because if it's a very proximal injury, if it's a mixed nerve, and if the distance to regeneration to the first muscle belly is long, then the amount of time that is required for this nerve to regenerate is such that you may well find that the motor end plates are by and large no longer functional, and 12 to 18 months following surgery is not the time to then start thinking about nerve repair. Think about the age of the patient, because as you know yourself, young children tend to do well with nerve repairs and they have good cortical plasticity, so they actually do tend to recover well in terms of sensation as well. And the other thing that we need to think about is, what are the patient's needs? Because quite often, somebody may need to use the hand for financial or economic reasons. Not everybody has the luxury of living in a country with social security and so on. And quite often, if people are not able to work and they're not able to feed their families, life becomes extremely difficult. So therefore, if you do repair a nerve, you're going to be waiting for at least 6 to 9 months in terms of looking for recovery. And even then, that recovery may be grade 3 or possibly grade 4 and not sufficient for the patient to actually function as a normal individual doing the job that they want to do. And you may have to consider an early tendon transfer simply to get the patient back to where they want to be. And the last thing I would say to you is that you need to look at the extent of recovery, because if a patient has had a good degree of recovery, either from a primary repair or from conservative treatment, then it would be a brave surgeon who would go in and take down a nerve to put in a nerve graft to see if they can improve upon the results of the primary sort of treatment. So we come back to the business of the early transfers as internal splints. And this has been advocated in the past by several authors. The role of an early transfer is 2 or 3-fold. Firstly, it shortens the rehabilitation time. So for example, in radial nerve palsy, and we look at the functions that we need to actually deal with, the one thing that you want to really reestablish is strength of grip. And for that, what you have to do is to get wrist extension. So by doing a simple procedure such as a pronated teres transfer to the CRB, you can 6 to 8 weeks down the line, get the patient moving gently, and by 12 weeks, have a wrist which is well extended and therefore will allow power grip. The other thing that is important about these tendon transfers is if you do them early, it's not necessarily the case that you will get full recovery after reinnervation or full recovery when you're waiting for the radial nerve to recover with conservative treatment. And therefore, if there's a partial recovery within the tendon or the muscles that are supplied by the radial nerve, the tendon transfer that you've done as an internal splint will augment that and will make it easier for the patient to function in the long term. So the classic one, as I said, is pronated teres to ECRB. Claw correction obviously is a different matter with regard to ulnar claw. Now, when you're starting out, and when I look at the list of participants, I see very senior surgeons, but I also see some younger trainees. When you're starting out, I think it's actually quite important to analyze the problem systematically. And over a period of time, when you've done many of these, you can examine the patient quickly in clinic and reach some sort of an endpoint in terms of what you want to do. When you're starting out, it can actually be quite confusing to know how best to approach a given problem. And therefore, it makes sense to take a sheet of paper with 3 columns. What is the functional loss? And that's functional as opposed to the individual muscles that are not working. Then you, in the second column, you write down which are the muscles that are missing, what's not working. And then you make a list of things that are available to you so that you can match the second and the third columns. This is an approach that you would have seen if you read it in Richard Smith's book on tendon transfers, which unfortunately is out of print. It's an old book, but if you can find it in your library, it would merit you having a look at them or look at it because it does have a lot of wisdom and profundity. So radial nerve palsy, as opposed to a median or ulnar nerve palsy, is to some extent easier to live with. The reason for this is that, first of all, the functional loss can be very significantly decreased by giving the patient a wrist splint. If you give the patient a cock-up splint, and if the wrist can be extended, then it restores their ability to grip relatively easily, and therefore patients can function. Secondly, even if you have a proximal radial nerve injury, the sensory loss is basically over the radial aspect of the forearm and on the dorsum of the hand. And it's not of as great significance as it might be in the case of a median nerve, for example, or an ulnar nerve or a combined median ulnar palsy, where essentially you have a blind hand. And however good your tendon transfer, if you can't feel with your fingers, you're not going to use it as well. And the third thing is that if you're ever going to start out in life doing tendon transfers, start with radial nerve palsies, because the results of these transfers are much better than they would be in the more intricate transfers for ulnar and median nerve. So if you think about the deficits in a radial nerve palsy, basically what we are missing is wrist extension and finger and thumb extension. This is what we need to restore. When you look at a radial nerve in terms of an injury, there are various schools of thought. There are some people who would say that even, well, with the exception of an open fracture or contaminated wound, it makes sense to actually wait and see what happens. However, for example, if you have the Holstein whatever lesion, where you have a spike of bone and the nerve is likely to be impaled in that, you're not going to get a great deal better by just waiting to see what happens. Equally, if there is a possibility that the nerve might be entrapped in the fracture, and if you're going to go and fix that fracture, that nerve is going to be permanently compromised. So therefore, in those kind of situations, I think it makes sense to explore at that point in time. Now, in today's world, there's very little that is not possible to repair. But if the bed is good, if you can clean it, even if there's a loss of substance of nerve, you can put in a nerve graft. And especially if it's in the middle third of the forearm, the distance to reinnervation to the first muscle, which is going to be the brachioradialis and then the ECRL, is going to be between 90 to 120 millimeters, which in all probability will come back in about 4 to 6 months. There are other situations where if you've conserved the patient, where they've had what you suspected was a neuropraxia, if there's no recovery or no signs of recovery by 3 to 4 months. And this is on EMG, because clinical recovery in terms of return of power is always later than EMG and nerve conduction studies will show you. So if you haven't got any sign of recovery in a suspected neuropraxia by 3 to 4 months, it makes sense to explore. And if you've done a nerve repair, and if there has been no recovery in the proximal muscles by about 6 months, then you have to consider tendon transfer. Now, most of us who work in the world of hand surgery will very freely acknowledge the great help that we receive from our therapist colleagues. And this starts right from the beginning, from the point of view of assessment of the patient. Patients spend a lot longer with therapists than they do with their surgeons. They tend to talk to the therapist a lot more. And you will sometimes gain very valuable insights into the patient's personal life, personal problems and experiences, and their psychological state if you chat to your therapist. The other thing that that therapist will do for you is to make a splint as a trial so that the patient can get a sense of what it might be like if they have a tendon transfer. Now here you can see that somebody's been given a wrist splint, and that wrist splint has taken the patient from a flex position to a dorsiflex position, and you can see how much easier it is for them to hold the bowl or to change a gear shift. And that would give the patient confidence in terms of their ability to benefit from a procedure of this nature. Now, there are a whole series of names and transfers that are associated with tendon transfers to radial nerve. And I think what I'm going to do is to touch upon 2 or 3 of the significant variations before we move on to actually seeing how we need to do these procedures. So the classic transfer that was described was by Robert Jones, I think way back in 1920, where the pronated teres was used for the ECRB, and the FCU and the FCR were used to restore finger and thumb extension. But as most of us will probably practice, we tend not to use the FCU as far as possible, because it's much more important in terms of grip and in your ability to actually ulnar deviate the wrist to some extent. And this was shown very elegantly by the work of Paul Brand, who looked at the moment of forces around the wrist. And he therefore proposed that we should use the FCR rather than the FCU. And that tends to be my choice of procedure. We'll talk about this a little bit more, but I'm just trying to introduce some concepts to you so that you have an understanding of how we progress in our thinking about this. So if we make a list of the things that are available, sorry, let me just go back. Yeah, there we are. Things that are available to us if you want to restore finger extension. The classic Robert Jones transfer was to use the flexor carpi ulnaris for the finger extensors. Starr and subsequently Brand made the case for using the FCR, the flexor carpi radialis, to restore finger extension. And if the FCR or FCU were not available for whatever reason, or if you wanted to have independent extension of the thumb and index finger alongside the other 3 digits, then it was Boyce who suggested that you could use the FDS of the 3rd and 4th fingers to restore finger extension. I'll show you a case of that. I think the one thing that most people are agreed upon is the fact that if you want to restore wrist extension, most people tend to use the pronated teres, and it's usually inserted into the ECRB or a combination of the ECRB and ECRL rather than just the ECRL itself, so that you don't get radial deviation. In terms of thumb extension, if you want to restore that, most people would agree that the procedure or the tendon of choice would be the palmaris longus. If that's not available, as I said in the Boyce transfer, you could use a ring finger FDS split into 2 to give you independent extension of the thumb and the index finger separate from the other 3. So it's the FDS 3 that's used for these 3 fingers, but the FDS 4 that's used for the thumb and the index. And if nothing else is available, well, of course, you could think in terms of the brachioradialis, but that is extremely unusual. It's not been part of my experience. Now, what's important from our point of view is to look at the work capacity of the muscles. I'm sorry, is everybody able to see the titles, or are they obscured by?
No, that's fine. That's fine, Manu.
Okay, good. So if we were to actually look at this, and this is a comparison that was made by Dr. Boyce, you have donor muscles and you have recipient muscles, and you need to look at their work capacity to be able to match them up. So if you look at the palmaris longus, for example, it's 0.1 and the EPL is 0.1. So that will tend to work reasonably well. If you look at the brachioradialis, that's 1.9. And if you put it in the ECRB or the ECRL, it's 1.1 or 1. Sorry, I beg your pardon. It was the pronator teres is what I was going to show you. The pronator teres is 1.2. And if you put it into the ECRB or ECRL, they're reasonably well matched. Now, if you look at the FDS and the FTP, these are much stronger muscles. And when you start using them for finger extensors, there can be a bit of a mismatch. So therefore, we need to think about this. And if you think of the brachioradialis as compared to the EPL, if you use that, well, that's significantly more powerful. But in addition to this, the other thing that we have to think about is the excursion of the muscles, because if you have a muscle with a very short excursion transferred to something which actually requires a long excursion, for example, if the finger extensors require between 3 and 5 centimeters of excursion, and you use a muscle which has 1 centimeter of excursion, then that tendon transfer is not going to work very well. So therefore, to come back to what I talked about before, the standard transfer that was described by Robert Jones was FCU for the EDC. The FCR was championed by Starr and subsequently by Brand. And the superficialis was used by Boyes, FDS3 for the EDC, FDS4 for the EPL and EIP to give you independent extension of the finger and the thumb. And this is just a slide that shows you what was originally done. And there were 2 variations of this transfer, just for your information, so that the FCU and the FCR were both used. Now, this is a schematic, and I'm just showing you a few diagrams before I show you my operative slide so that you know what to do. But this shows you how the pronator teres is transferred to the ECRB. And what you will note here is that as the pronator is inserted into the junction between the middle third and the distal third of the forearm of the radius, what we tend to do is to take a strip of periosteum to extend this tendon so that you're not handling the actual end of the tendon, which is what you want to suture in, and therefore it doesn't become frayed or crushed. This diagram shows the FCU being used. It's not in my procedure of choice. I tend to use the FCR. You can take it around and it shows you that it is being woven through the EDC. Well, that's not something that I would tend to do. If I'm doing a tendon transfer for a patient, it would normally be because I think that the patient is not going to recover function in the long term. And as I will show you in my subsequent slides, I tend to transect the EDCs and pass them through the FCR so that I can tension each finger individually. And here you can see the PL, the palmaris longus, being transferred across to the EPL to get abduction and extension of the thumb. This is the Brand variation, and in the Brand variation, instead of taking the FCU, what he showed us was that you could use the FCR. And you will note that this transfers outside of the retinaculum so that it doesn't snag. Well, actually, it depends, because if you've taken, or if you've got long tendons here, if you transect them more proximally and you have enough tendon length to pass through the FCR, as long as it doesn't snag on the retinaculum, you could actually do the repair with the tendon still coming through underneath the retinaculum, or at the very most vent the proximal part of the retinaculum to let it lie distally. So here's an example. As you can see, this patient is unable to extend the wrist and unable to extend the fingers and the thumb. Now, the incisions can be a matter of choice, but by and large, what works for me is a dorsal midline incision, which will show me where the extensor retinaculum is and will allow me to have enough access to the EDC tendons at this point to be able to weave. Here's a diagonal incision, and sometimes you have to go further distally on the radial aspect of the forearm, because as you will know, your pronator teres is going to come diagonally across the forearm from the medial epicondyle to be inserted into the junction of the middle third and the distal third of the forearm. And in order to harvest the FCR and the palmaris longus, I tend to make an L-shaped incision, which again, you may have to extend depending on where the muscle belly and the tendon are situated. Now, a lot of people find it difficult to identify the pronator teres for a procedure of this nature through relatively limited incisions. But what I would say is that if you sighted it properly, if you take a retractor and move the brachioradialis to one side, you will see a diagonal tendon being inserted into the radius. That is the pronator teres. And here you can see, as I demonstrated before. Perineum, which I will incision along the bone. That's the periosteum being elevated, and you can see that I've delineated the tendon of the pronator teres, more clearly seen here. And as we go further, I will make a little nick with the scissors along this until I start seeing the muscle belly. And then I'll free the muscle belly up much more proximally, because what you want is a free glide of the tendon where it isn't getting caught on anything. Here's the incision on the volar aspect of the forearm with an L shape. And you can see the palmaris, this is the FCR and the palmaris longus. And both of these have been divided distally. And as you can see, I'm gently separating the tendon from the fascia and equally the muscle, so that you get the length of the muscular tendinous unit, which glides freely and is not catching across a corner. Now, when it comes to putting the EDC into the FCR, my personal preference is to identify the EDC tendon. And you can see here that I'm positioning the hand in full extension, and my assistant will extend the fingers as well, so that I can set this at a reasonably good tension, because the flexors will always overpower the extensors. So what I will do is to actually divide the FCR, divide the EDC, and then make 4 openings separately as slits in the FCR, pass each tendon through it. And I'll show that to you in a minute in another picture. And then tension each of these and put in a stitch so that the fingers are held in extension. Now, the question is, how do you judge this? And what you do is a tenodesis test. So you can see here that I've passed the 4 EDC tendons through the FCR, and I've sutured each one in place with test sutures. There's the palmaris longus that's been harvested, and it's been put into the EPL with a pulvertaft weave, how apt. And now this is what we do in terms of the tenodesis test. So as you can see, when you extend the wrist, you should be able to get flexion of the fingers. When you flex the wrist, you should be able to get the fingers to extend. And if that happens, then you know that you've got the right tension. Equally, as far as the palmaris longus is concerned, by flexing the wrist, you should be able to get the thumb down when you extend. Sorry, the thumb back up, and when you extend, the thumb should flex. So here you can see that as I extend the wrist, the fingers are flexing. And when I flex the wrist, the fingers extend. So that means the tension is pretty much okay, as it should be. So things to consider. What about if you haven't got a palmaris longus? So you can actually transfer the FCU to the EDC and the EPL, but this is an exception to the rule of 1 tendon, 1 function, which I talked about earlier. Or you can switch to a Boyce superficialis transfer, where you take out 2 FDSs instead of a PL and the FCR. And you can do 1 FDS into the thumb and the index to give you the EPL and EI, and then the other one for the other 3 fingers. So this is what a Boyce transfer would look like. You take a pronator teres to the ECRL and ECRB, but mainly to the ECRB. You do an FTS3 to the EDC. You do an FTS4 to the EI and EPL, and then you can do an FCR if required. And this was Boyce's sort of thing, but I don't actually do this myself separately. I would rely upon what I've got here in terms of thumb abduction and extension. So here's the patient I showed you earlier. You can see that he's unable to extend the thumb or to extend the fingers. This is a diagram drawn by Mr. Mahendra Kulkarni, who worked with us many, many years ago. And he's listed the transfers that we've done for this particular patient, because I was using an FTS4 for EPL and the EI. So you can see the incisions in this patient. I've identified the 2 wrist extensors. There's the pronator. And once again, I'm taking an extension of a periosteal strip. As you can see, the muscle belly has been dissected out. We visualize the FCR dissected proximally to free up the muscle belly and divide that distally. Now, in this case, I'm going to be using the FTS, and you will have different ways of harvesting it. But I think this is a useful thing to learn, which is a small incision in the distal palmar crease, just distal to that. You identify the FTS by flexing by pulling on the tendon and flexing, and you should be able to make sure that the distal joint doesn't flex. There are no marks at this point for taking out the FTP. We then pull on the tendon as hard as we can with a tendon loop here, as you can see, and you take a pair of scissors and slide this as far distal as you can. Now, if you do this because you're pulling the tendon out, just as you may have seen in flexor tendon injuries when somebody's trying to grab a knife, the cut in the tendon is at a different level to the skin because it actually retracts distally. So similarly here, by making this cut with full flexion of the PIP joint, but making sure that it's the FTS and not the FTP, I will be actually transecting the FTS just proximal to the chiasma, which is more than enough length for me to be able to do what I need to do without having to open the proximal segment of the finger and open up the flexor sheath. So there we are. I've identified and divided the FDS. We locate it more proximally in the forearm, find the muscle belly, and then pull it out and pull it through. There's the FDS. Now, here's a point that you have to be careful about, that when you actually move it across onto the dorsum, you have to be careful that you don't cause compression of the median nerve. I have done this on one occasion. The thin bellies of the FDS or the tendon can compress the median nerve. So the next morning, the patient still was completely numb in the radial 3.5 digits, and he could feel the ulnar side completely. So then I knew that it wasn't necessarily the block, and I had to go back in, take the tendon down. And if you look at the median nerve here, there's a site of compression. This patient went on to recover fully, but it taught me a lesson. And therefore, I've since then tended to go through the interosseous membrane rather than around the forearm. There you can see the bit of bruising and swelling in the nerve. So then we come onto the dorsum of the hand. And at this point, you can see the retinaculum there. And as I said before, you can partially divide that. By identifying the various tendons, you can dig out the EPL and the EI. And by giving proximal traction on this, you will see extension of the index finger and the thumb, so you know you've got the right tendons. And as you can see here, the FDS is going to come through onto the dorsum, through the interosseous membrane, taking care not to catch the median nerve. And here you can see in this artery clip, the EPL and the EI. And when you pull on them maximally, you see full extension of the thumb and extension of the MCP joint of the index finger. So you can take this FDS and weave these through these two tendons through the FDS tendon at the right tension to maintain that extension of the thumb and index. Similarly, as I've said before, you can pass an FCR through. I tend to limit my harvest of the FDS because the FDS harvest is not a completely benign procedure. And if you look at it, I mean, it's in another lecture, it's on the ulnar claw lecture. But if you look at the residual mobility of harvesting an FDS, almost 80% of fingers from which an FDS has been taken out will show you either a flexion contracture of some sort or a swan neck deformity. So as far as possible, I avoid taking the FDS unless I have absolutely no other options. And in this patient, I've taken the FCR. I'm going to put the 4 EDC tendons. So as you may remember, I said, I trace the tendons back as proximally as I can and divide them so that I have enough length of tendon to pass through the FCR. And then once I've done that, you do a tenodesis test. So when you extend the fingers will flex, when you flex the wrist, the fingers straighten. Equally, look at the position of the thumb. When you extend, the thumb flexes sufficiently to almost approximate the index finger, whereas when you do the opposite, the thumb extends and it opens up, which means that the tension is about right. And that's the postoperative result for the patient. So this is the same patient I showed you before, who wasn't able to extend his thumb actively, wasn't able to extend the index finger, and couldn't extend the wrist fully. And here you can see, look at the position at rest, and you can see that he can flex fully. He's able to extend the wrist, and you can get good flexion, good extension of the MCP joint and the IP joint of the thumb. But equally importantly, I would point out to you that you must remember in these patients, it's equally important to make sure that you set the tension right so that the patient can flex. because you don't do the patient any favors if you've got a hand that is fully extended, but they can't flex to make a grip, because that defeats the purpose. The whole point is to reposition the wrist in extension like so that they can get strength of grip back. And if you've set the tendon so tight in extension that they can't make a fist, then actually it's not helpful to anybody. It's not usually the case, because the flexors usually overpower the extensors in the long term, but it is a point worth making that you must do the tenodesis test to make sure that you've got the right tension on the tendon. Sorry, so here we are. And you can see that's a patient pre-op, that's a patient post-op, and it's a reasonably good result. Now, in the old days, people would suggest that you splint above the elbow and leave the elbow at 90 degrees, mid-bone, et cetera, and leave them alone for 5 weeks or 6 weeks and whatever. And, after 6 weeks of immobilization, edema management, functional retaining, et cetera. But from our point of view, we know from the experience of looking after patients who have had, and this is 1995, even as late as that, they were saying complete immobilization of the transfers is required. Well, we know from our experience of doing flexor tendons and extensor tendons that active mobilization is possible. And once again, we would imagine that in 1989, when the paper came out on early active mobilization of flexor tendons, that we were doing something new and great. Here's the quote from Richard Smith, 1987, immobilization required for at least 3 weeks. But it was the work of Gelberman which actually started showing the benefits of early intermittent passive mobilization. It was Brand who suggested that it would be good to allow relatively early passive movement at 10 days. And then, of course, we have our own experience of flexor tendon injuries and extensor tendon injuries, which takes us on to moving these tendons early. But I think once again, the hand of history rests upon us. And way back in 1916, Mayer was saying that whenever the typical physiological fixation has been possible, it is safe and wise to begin active exercise of the transplanted tendon a few days after the operation. So there's really nothing that new in the world of surgery that people have not done before us. So we've talked about early mobilization of tendon repairs in the injured state, but also there's sufficient work now to show that it is safe to mobilize tendon transfers. And my colleague Nitin Vaingankar, who was with us many years ago, took this paper to the BSSH a long time ago, where we moved our tendons early. And here's a patient who would have had a radial nerve tendon transfer, and on day 5 would have been put into a dynamic splint to get moving, so that you get glide and you don't have adhesions. It actually shortens the patient's recovery time quite significantly and makes it easier. So you can see here good flexion, which is important as getting extension and full extension. And here's another elderly gentleman who had multiple level cuts in the proximal forearm. And if any of you have ever explored the posterior interosseous nerve, you'll find that, or you will remember that it's actually not the easiest thing to repair if there were multiple lacerations going through muscle and nerve at that point. Now, it is, of course, possible to graft that nerve, and I have done it myself, but because he was about 72 or 73 years of age, and because he still had wrist extension, the choice was to proceed straight to tendon transfers. And that's the kind of result that you can obtain at about 12 weeks from an operation of this nature. And once again, I draw your attention not just to the fact that we've achieved extension of the thumb and of the fingers, but actually, as I said before, we still have full roll-up of the fingers. And as I showed you in this case, this is a different patient, full flexion of the thumb at the IP and MCP joints as well. So that brings me to the end of this talk. I hope you found it useful, and hopefully it'll give you enough guidelines to be able to undertake a procedure of this nature if you do have to yourself. And hopefully you also got a little bit of insight in terms of how to assess these patients, how to time your surgery, and how to make the right choice, and how to counsel your patient appropriately for this. Thank you very much.